Здравейте, колеги! Добър ден! Огромна привилегия е за мен да открия първата сесия на 11-тия конгрес от името на Организационния комитет. Благодаря ви за присъствието. Първите сесии ще бъдат обучителни и ще бъдат насочени към млади интервенционални кардиолози. И имах честта да бъда нагърбен с тази задача, да направя тази сесия и да помоля моите колеги доктор Димитров и доктор Александров да ми помогнат, за да може, както се казва, от млади на млади, да можем да си помогнем да подобрим нашата практика и да можем да вървим напред заедно, без да закъсняваме повече, защото мисля, че трябва да вървим стриктно по програмата. Ще дам подиума на доктор Димитров да представи неговата презентация, която се казва "Как да избера въвеждащ катетър, активен и пасивен съпорт". Заповядайте.
Да, благодаря. Здравейте на всички. Доктор Димитър Димитров от Александър Чирков в София. Благодаря на организаторите и на Ники Стоянов за поканата. Професор Стоянов още го няма, така че може би на български ще продължа. Темата е как да избера правилния катетър. Започвам с един любим мой цитат: "If you fail to plan, you're planning to fail." Както един от първите ми учители ме учеше, дилатацията е не само в твоите ръце, предимно е в твоята глава. И идеята е винаги да знаем предварително какво искаме да направим преди да го направим. Каква е целта на водещия катетър? На първо място целта на водещия катетър е да канализира коаксиално коронарните артерии и да ни даде достатъчно добър съпорт. На второ място да осигури непрекъснат хемодинамичен мониторинг, да можем да доставим достатъчно количество контраст, за да опацифицираме коронарната анатомия, да е кинк резистент и да задържа своята твърдост при продължителни процедури и да има достатъчно голям вътрешен диаметър, за да можем да доставим съответните девайси. В интерес на истината, първата дилатация, която опитал професор Грюнцих, е била една година по-рано от успешната му и първият път не е успял именно заради това, че не е имал подходящ катетър. Имал е катетър някъде с скривка между Judkins Left и Multipurpose през брахиален достъп. Т.е. още в началото на нашата професия водещия катетър е играл основно значение. Структурата на водещите катетри от 80-те е еднаква. 3 слоя: вътрешен, среден и външен, които позволяват на катетъра да бъде кинк резистент, да бъде торкабъл и да задържа своята кривка, която му е заведена от производителя. Тук съм представил някои от фирмите производители на водещи катетри. Не всички катетри са еднакви. Най-широко използваните катетри в България, Cordis и най-вече Medtronic според мен. На ланчера разлика има в катетрите. 6-френчовия катетър на Cordis е с вътрешен диаметър 1,78 мм, докато на ланчера е 1,8 мм, което понякога е от ключово значение. Структурата на един водещ катетър с първична, вторична кривка, шафт и с хъб, като има и тип, който е с радиопактен маркер. Разликата между първичната и вторичната кривина в сантиметри дава размера на водещия катетър. Повечето катетъри имат и третична кривина. Опората. Най-важното нещо в нашата работа, когато тръгнем да правим една дилатация, опората е два вида: пасивна и активна. Пасивната е тази, която е заложена от производителя в катетъра и не зависи от манипулацията от оператора. Определя се от няколко неща: размер, вид кривка, коаксиална позиция, достъп и използване на дълъг шит. Размера е от значение. Колкото по-голям размера на катетъра във френчове, толкова по-добър съпорт имаме. Повечето дилатации могат да бъдат успешно извършени с 6 френча, 5 френча по-рядко, но комплексните процедури за мен лично изискват задължително минимум 7 френча. При използване на 5 френчов катетър винаги внимание поради наличен вентури ефект. Когато поставяме девайси през Y конектора, много лесно влиза въздух и ако не се флъшне катетъра, имаме висок риск от емболизация газова. През 6 френча може да бъде поставен балон и стент, но не и 2 стента. И не всички гайд екстеншени минават през всички водещи катетри, като ланчер е изключение. 7 френча лесно може да се използва през радиален достъп, особено при мъж. Тук съм показал основните девайси, които могат да се използват през 5 френча: всички коронарни балони, всички коронарни стентове, IVUS катетри, 6 френча, през 6 френчови катетри използваме системи за протекция, OCT катетър, рота бър до 1,5. И така, и така, и така. 7 френча, 2 стента симултанно могат да бъдат поставени. През 8 френчов водещ катетър може да използваме IVUS катетър с микрокатетър Corsair. Интересна система Сахи Шитлис, лично в нашия опит използваме доста често. За съжаление вече няма да се продава в Европа, но системата е направена така, че се използва катетър Дезиле, като с външен диаметър водещ катетър 6,5 френча имаме вътрешен лумен на 8,5 френчов катетър, което позволява отличен съпорт и доставяне на различни девайси. Пример за това е тази стволова стеноза, дистална стволова стеноза, високостепенна, с изключително тежка ангулация на циркумфлекса, XB3,5 8,5 френча, през радиален достъп, един водач в ЛАД, микрокатетър с флопи лайер, доста трудност да се достави в циркумфлекса. Водача вече е стентирано ствол към ЛАД и трябва да се рекросне през стента в циркумфлекс с 3 водача, единият джелнат, другия трябва да мине през дисталния страт на стента. Виждате, няма никакъв проблем манипулацията, няма фрикция, няма оплитане на водачи. ТАП отново без проблем и финален резултат през радиален достъп. Известен е това, което Бърнат Майер казал, че всички дилатации могат да бъдат направени 6 френча, с изключение на такава, която се прави от един французин, тогава става 7 френча. Джъткинс, рентгенолог, който е измислил най-известните катетри и кривината им, и известна негова кривата фраза е, че неговия катетър знае къде да отиде, освен ако оператора не го спре да направи това. Джъткинс катетрите са най-атравматични, но естествено те дават най-малък съпорт. За мен основната им употреба в днешно време трябва да бъде единствено при стволова стеноза, при остеална дясна коронарна артерия или при проксималния тип А лезии. Когато има нужда от добър съпорт, не би трябвало да се използват тези катетри. Имат първична, вторична и третична кривка, които осигуряват коаксиална позиция в ствола на лявата коронарна артерия. Няколко сценария, когато имаме малък катетър, а голяма аорта, катетъра застава не коаксиално, винаги върха сочи нагоре към ствола и при силно впръскване можем да направим тежка дисекация, затова трябва да се внимава. По принцип манипулацията на малък катетър е по-лесна, отколкото на по-голям катетър в аортата. Бутайки катетъра надолу към аортните платна и манипулация по посока обратна на часовната стрелка вкарва катетъра в ствола, макар и не коаксиално. И обратния вариант, когато има голям катетър за малка аорта, вторичната кривка виждате, че е високо в възходящата аорта и върха на катетъра застава под ствола на лявата коронарна артерия. Когато имаме къс ствол или практически два отделни остеума на коронарните артерии, ротация по посока на часовниковата rotation on towards the LAD is caused by clockwise, anti-clockwise rotation, and if you want to engage the circumflex, you have to torque counterclockwise. So usually shorter guides are used to engage the LAD and vice versa. When we use the radial approach, one needs to use shorter catheter than the femoral route. Amplatz catheter, maybe forgotten catheter, which gives excellent support if you know how to use it, but there is no free lunge, there is a high risk of dissection. So Amplatz left can be used in short left mains, PCI of the circ or the RCA, where it gives perfect support. Size 1 is for small aorta, size 2 for normal, size 3 for dilated one. If the tip of the guide does not reach the ostium of the left main and lays beneath it, it's too small, and if it's above it, it's too big. So we can, from different manufacturers, we can divide the Amplatz guides to two groups, one with big length of depth from the primary and secondary curve, and ones with a short one. They are manipulated differently. When the first group, when you engage the coronary artery, if you pull them out, they engage deeper and are likely to cause dissection. And if the difference between the primary and the secondary curve are smaller, then pulling the guide back disengages the coronary artery. As a main rule, when we use the Amplatz, if you have finished your procedure and you want to take it out, you don't pull it back forcefully, because this most of the times causes deep engagement and you can easily dissect. So it's the other way around. You push the catheter towards the aortic valve and turn it counterclockwise, then you disengage safely the coronary artery. The extra backup or ABU or different names for the same guide is the perfect guide for left coronary. PCI procedures, especially when we have long left main. For me, short left main is prone to dissect and it should not be used. Because of its big secondary curve, the guide often gets coaxial position and much of its length is of the secondary curve is laying on the aorta, so it gives perfect support. The Ikari catheter, designed by Terumo for transradial procedures, it has the same passive support, but ability for it has better passive support and the same ability as the active support. As general, the femoral root gives the operator better support most of the times, especially when you have kinking of the innominate artery. Through the femoral, you can use bigger catheters, long sheet if needed, and so on. So what about the active support? When the operator needs to finish his procedure or is not able to do by any other means, you can use active support, which almost always means deep intubation and has to be done only when all other maneuvers have been tried and failed. The Judkins catheters can be unpacified. With the left hand, you pull the guide over the wire and the device which are in the coronary, and you can intubate deeply. In the RCA, you can you always have to do it with clockwise movement. The Judkins are best for this. Ampots and XB guides are very dangerous and are prone to dissect. So some examples, we have an RCA CTO that was crossed with a wire, but the balloon would not follow through. So we used all we could do, even the guide extension, and after nothing helped us, we intubated deeply the Ampots guide. So we were able to pass and to place the stent. This is from my friend Nikolai Stoyanov's case he sent me. So you see there's a severe stenosis. Most probably this was an acute coronary syndrome. They tried to place the stent, but it would not pass without predilation. So they engaged deeply, and you see the stent would pass through very easily. And then you have the final result, perfect final result. So what else we can do? We can use guide extensions. They're very popular nowadays, different manufacturers, different extension catheters, so they always give good support. In my humble opinion, unfortunately, if you don't have a good support of your guide, this would not help. They always have to be advanced over an inflated balloon and a wire. So we have the first one, the guide one. So they are 150 centimeters working length, 25 centimeters most of them. So for the sake of saving time, I will skip. This is the case where we have stents in the proximal RCA, distal lesion. The devices would not pass, so I had to use an inflated balloon and try to place an extension. I think it was guide zeros, I don't remember, but it was stuck on the previous struts of the stent, so I used the balloon in front of the guide and to pass the extension over the balloon. So this was successful here, and the balloon is again in front of the catheter here distally, but it's not inflated, and that's why if you don't inflate, you have a problem. Yep. If you don't inflate the balloon and advance the extension, you can end up like this. So dissection. So another thing you can do when you have a problem, you have the guide, you have the wire in, you have some dissection, or you don't want to lose your position, just like this case, which I obviously misinterpreted. I had this was a male with critical stenosis of the RCA. I knew that I would have problems, so I chose, I think it was Ampot's right guide, but you can clearly see that it's not suitable for this. Either way, I continued, passed through the wire, I would say good coaxial position, extension, but the balloon would still not pass. And every time I tried to withdraw the extension catheter, the guide would buckle out. So I changed to femoral route, a new Ampot 7 French left 2 guide, guide, and withdrawing the first guide into the aorta, I was able to place the second guide, another wire, better support, good coaxial position, and the procedure was finished for me with an acceptable result. So my main take-home messages is each PCI starts with choosing the right guide. An investment of some time to think about the guide can make a difficult PCI easy, and an easy one a nightmare. Thank you very much.
Thank you. Thank you. Excellent job. Before to give you the time for the question, I want to introduce, but we don't need, he doesn't need introduction. It's a Professor Sianos. It's a huge privilege to be with us and to co-chair this session with us. Do you have any questions about the guiding support, passive, active support?
I do have only one comment, if I may say. You commented on the fact that when you want to deep engage with a guiding catheter, you have to hold with your left arm the materials that are in the,
no, with the right.
The right arm, the materials that are in the coronaries, and then you push. In my view, that's not the most effective maneuver, because essentially the materials that you're having in the coronaries, they're not anchored. So they're not stabilized anywhere. That means that if you push them, essentially you push them and then they don't offer any more advantage in advancing materials. The right maneuver to do that is essentially by having the materials in the coronaries to hand the guiding catheter independently from the materials in the coronaries.
That's what, I'm sorry, that's what I meant. Maybe I didn't say it like I should have. You hold firm the wires and the balloons.
No, that's what I'm saying. That's not the most appropriate maneuver.
Okay.
The most appropriate maneuver is you use these as a roadmap and you handle the guiding catheter completely independently, and then by the rotational force that you exert to the catheter, it goes deeper. Because you have to have action and reaction. Action means that I stabilize something distally, then I hold it and I push something. This is not happening in the coronaries. For instance, you do anchoring, you inflate the balloon in the coronaries and then you push. This is an anchor point. Yep. If it's not anchored, there is no reason to pull anything. It doesn't help. So the way is that use them as a roadmap as they are, and then use the guiding catheter independently from the materials, and with the rotational force you can achieve deep engagement.
Yes, but you still have to hold them. I mean, if you
not necessarily. Absolutely not necessarily. The very first thing that I'm talking to the fellows, you have them down, use them as a roadmap, you don't need to hold them. The valves today, they don't stabilize. You have these push valves that they allow the movement of the catheter around the materials. So you just independently handle the catheter with the materials in situ, and you will see the effect that it is far more better as compared to, because essentially when you pull, you pull. There is nothing anchoring there.
No, thank you. I'll try it. Yep. Thank you very much for the good tip.
And I want to ask you something, because in my mind, in the regular PCI, not so complex scenarios, and it's my task for the second talk is, and I want to ask you to help me. Can you explain one more time about the active support? Because the most common situation is to start with really six French regular guiding without with weak support usually. Can you explain how to engage deep into coronaries?
I think that Professor Sianos just mentioned that, so maybe he should comment on that. Maybe he's much more experienced.
Just the movement, counterclockwise for clockwise for the right coronary artery.
Time for the right coronary artery, what you do is that you rotate clockwise. And the reason is, why is the catheter diving? When you rotate clockwise in the right coronary, it's not about saying something that has an effect. Why? Why you rotate clockwise and the right catheter is diving? Because when you put the catheter into place, the aorta is 2.5 centimeters. You push through the femoral or the radial. It's different, the approach from the radial approach. Let's say from the femoral. And then the catheter takes the outer rim of the aorta. When you rotate the catheter dives from the upper part of the aorta to the lower rim of the aorta. These 2 centimeters, you gain them in length. And that's why the catheter is diving. It's the same thing, regardless of the PCI. When you want to engage the right coronary artery, what do? You go to the cusp and then you pull back and rotate. Why do you pull back? You pull back because when you're rotating, the engagement goes from the upper rim to the lower. And then the catheter is. If you continue this movement further down, then you reach, not in all occasions, if you have a Shepherd crook right, this, that, there are other things that you need to do. But generally speaking, and the vice versa, today we don't use Judkins left catheters in the past. We're using them regularly, and actually they are the best as far as you can push the secondary curve of the Judkins left down to the cusps. Then the primary curve faces coaxial with the left main, and then you have the not amplat, super amplat support. But the EBU catheter is a catheter that doesn't need very much. Essentially, when it's sitting in the left main, the things that you have to do, essentially slide rotations 1-2 degrees, and then just pushing. And if you have the right size, then you get the right backup.
Excellent teaching points, thank you. And without any further delay.
Okay, thank you. Now I'll ask Dr. Stoyanov to tell us about the standard PCI and can we underestimate it?
If necessary to give the lecture in English, in Bulgarian is not a problem, please. What is more convenient for the... keep it in Bulgarian and we can do the talking in...
We were prepared for both scenarios.
Okay,
Our
please.
slides are in English and
no
we can continue
whatever, I think
in English
Bulgarian
if you
might be easier.
don't.
Okay?
Okay.
All right.
I think to continue in English, if you don't mind. My task is not so easy because it's in our everyday practice we face of these scenarios probably every week. To start regular PCI with our 6 French guidings that we are really experienced with, but we need more support, and we should have in our mind how to increase our support and to have step-by-step approach and to have a better results. This is really common situation to start our ACS patient or stable coronary syndrome patient and to have a weak support and cannot deliver our materials into the coronaries. And I'll try to give you some tips and tricks and step-by-step approach how to deal with not so complicated lesions and scenarios, but in our everyday practice. Already Dr. Dimitrov gave her talk, and it was excellent overview about the guiding catheters and how to choose more supportive guiding catheters and how to perform active support. That's why I'll continue directly with wire-based technique. What does it mean in my mind, wire-based technique? First of all, if you don't have a good support and your wire is not in really distal position, you can correct the distal position of the wire, and you can have a better support and to change the coaxiality of your guiding and just to deliver your materials. But you should keep in your mind that this can create a distal perforation, and that's an important issue, and you should keep this really in mind. The technique that you already know, it's really old technique, but extremely useful. It's body wire technique. This technique was described in 1992. And this on to put 2 wires in the same vessel to increase the support. The bit more supportive is if you insert into a coronary artery more supportive wire, and that's why you should really know the wires and the extra support wires. In my mind, the mostly used supportive wires are Ironman and also Grand Slam, and probably and you can also try with CM Blue extra support, because these wires provide extremely good support, but you need for the first two choices, Grand Slam and Ironman wires, you need probably micro catheter to deliver these really supportive wires into the distal bed of the arteries. Otherwise, you can try plenty of times to deliver these really stiff body wires to the distal part of the artery, and you failed. That's why the most common technique is to go to the distal bed of the artery. After that, to deliver the microcatheter and to exchange with a really supportive wire. And this provides extreme support. You can manipulate easily the guiding catheter. And if this failed, you can put another softer wire and to use this wire to deliver your materials with the support of the extra support wires. And this is an example for body wires, but probably this is not the best example, as I mentioned, because the wires are not in the really distal position, and as you can see, the guiding is not really well engaged in the coronary artery, and the support is still weak. The other techniques that Professor Sianos already mentioned is about the anchoring technique. These techniques are balloon-based technique. The first technique that I want to share with you is the side branch anchoring, but in most of the cases you need larger size guiding catheter, as a 7 French guiding. You need a second wire in the side branch. You need to have a good angiogram and to select the best branch, and to insert a small balloon, and this balloon can be inflated during the procedure if this branch doesn't provide collateral for the distal bed of the artery in CTO cases. For the regular cases, it's more or less safe to inflate balloon in the side branch and to increase your support. This is really useful technique when you have osteo lesions or the artery is not so big and you cannot engage deep with your guiding catheter, because you can create a huge dissection. The other technique is the distal anchor technique. This is not so common, but you can deliver your balloon distally, inflate the balloon, and to engage deeply with the guiding catheter, or to have a second wire and fix the wire in the distal bed and to deliver your materials and more proximally. But this is not really common technique. Dr. Dimitrov already mentioned about the guiding extension catheter. This is my first choice. I really like these tools. I really use in more and more extension catheters, and with some of the companies they provide also the 5 French extension catheters. This is really useful if you want to perform PCI with 5 French guidings in small ladies through the radial approach, because we really love radial approach, and sometimes we need support, and the 5 French catheters doesn't provide really excellent support really often. And this is one of the tricks that you can use, and how to engage the artery with the guide extension catheters. There are several techniques, but the most common, and that it's really recommended, to use a balloon. The first technique is to inflate the balloon at the end of the guiding extension catheter, and during the deflation to proceed with your guiding extension catheter, and like that, millimeters to millimeters, when it's really calcified and tortuous anatomy, you can reach the portion of artery that is a region of interest for you, and the region to deliver your materials there. The other technique, it's like a distal anchoring technique, and you can deliver the balloon really distally, inflate the balloon, and to proceed with your extension catheter, guiding extension catheter. I want to share with you one case example. It's a 60 years old male patient. I'll try to show you really step-by-step approach, and it's a real example in my mind how to deal with such lesions. This is Judkins right catheter, and in stable coronary syndrome patient, CCS3. How many of you will proceed with this catheter for this regular PCI? Please raise your hand. Nobody. Okay, probably it was the mistake of the operator, but he continued, and quite well he delivered the balloon, 2.0 balloon, after that 2.5 balloon, and this was the result, and unfortunately it was implanted one stent proximally, and this is the post-dilatation, and you can appreciate that support is extremely weak, and we need to do something else. The patient was stable and was lifted at this stage, and this was the result, but the patient had chest pain. Also during the exercise that we decided to do something for him, and that's why I chose Amplatz left guiding catheter. This is really important to know how to use larger catheters and with more supportive curves. And for the right coronary artery, as Dr. Dimitrov said, the Amplatz left guiding, it's really useful. My first choice to increase the support is the guiding extension catheter. As you can see, this is a 6-phase guiding extension catheter, and it was relatively easy to reach the distal portion of the artery. We deliver the balloons, all the materials that we want, and finally we finished with one stent and acceptable final result. My take-home messages are that I want to start step by step, and the first step is really to choose proper curve and proper size of your guiding catheter. And my second message is that if your approach failed, it's not a crime to change your guiding catheter and the curve or the access to have a larger guiding catheter to have a better result, because better not only short-term result and also in long-term result. And my advice is to spend some time to understand about all the materials and the stiffness of the materials, how to use them properly. And finally, I really love to use guiding extension catheters in my daily practice, but only problem is the cost. Thank you.
Thank you, Dr. Stoyanov. That was an outstanding lecture. Any comments? Any questions from the audience? The panel, please.
Yeah, I have one question. When you choose the proximal anchoring balloon, how do you choose the size of the balloon according to the vessel?
Depends on the vessel. I am doing a few angiograms, and after that I'm inserting the wire and putting balloon there. If the support is this provide good support, I don't inflate the balloon usually, but if we need to inflate the balloon, about the size of the balloon,
Yeah.
I'm choosing one-to-one size
1:1.
of the anchoring balloon.
Because on the presentation
This
it
balloon
was,
wasn't inflated. This balloon wasn't
I
inflated.
thought it was 1.5 or something.
Yeah, probably. But in this case, the balloon wasn't inflated, because sometimes when you have a problem with the support, you just insert the anchoring balloon in the side branch, and it's enough. Sometimes no. And probably you will share with us some cases about this. Yep.
Thank you very much. I would like to ask you and maybe Professor Sianos what is his opinion. If you don't have a guide extension, can you safely make homemade? Have you used it lately? If you don't have a guide extension, you have big issue. You don't have it on the shelf. Have you got any experience with cutting the guide and placing another 1 French less guiding cutter inside the first one and use it as an extension? For example, 7 in fright, the original mother and child technique. Because once or twice I have used it, but I was a little bit skeptical. I don't know about your opinion.
It was question to you. At the beginning, the first guide extension catheter, I say, if in my mind, was the hard trail catheters. They're a bit longer, 5 French, but you need to use another technique, or because it's 125 as longevity, and you should really adapt your technique to this. The first described, I think, technique is with this kind of catheters, high trail, long 5 French catheters to have a deep engagement of the arteries. Nowadays, we are really happy with these new devices. But if Professor Rustianos can say something.
This was the devices that they were developed by Terumo, that they're not, I don't know if they might be available, but I mean, whenever, I don't use them personally, I have never done that, but my suggestion to all of these, because all of the examples that you showed, especially during this presentation, they were related to calcium. So there are situations that you have poor backup support based on the anatomy, because of the takeoff of the artery, because of the tortuosity of the subclavians, because of many other reasons. And sometimes you have extremely calcified femoral arteries that doesn't allow you to provide backup support. So it's not only about how the catheter is sitting. So there are many things that you might need to optimize in order to be able to have good backup support. The second thing is that instead of making solutions or shortcuts of how you facilitate things, solve the source. The source means that I do rod ablation, I do shock waving, I treat the coronaries in a way that I remove the source as to why I need backup support. So it's not only the thinking, but where today the session focuses on how manipulate guidings or how you increase backup, but keep in mind that sometimes the way to overcome the problems is to provide the optimal coronary treatment, and then these things are solved. So to come back to the question, I don't have experience, I've never done it, but I've never had the problem of finishing case when I apply all the necessary things to do them, yeah.
Because if you want to do that, you have to take a 7 French guide catheter to cut it, then to use the 6 French dilator, and then to advance with the shortened guide, a 5 French guide, for example, on an XB, and you can use it as a guide extension. It's the same principle for me. I've used it several times, but it's very risky. But if you have no other option, you don't have a guide extension or rotabar or whatever, for me it's a good option. Thank you.
Okay, thank you, Dr. Stoyanov. The last case.
I want to introduce Dr. Alexandrov, and his topic is about the complex PCI and how to plan the procedure. Please.
Thank you. It's a bit awkward to me to talk about complex PCI in the presence of Professor Tsianos, but I'll do my best. When I started preparing this talk, I understood that for 15 minutes I can't give any practical, really useful things to you regarding all these bifurcations, through bifurcation, calcified lesions, or CTO. So I thought that I might try to give you some more, let's say, philosophical insights for a complex PCI that I learned one way or another, most of the times the hard thing. Well, you know, the complex PCI, this is statement from three very esteemed gentlemen, and heavy calcified lesions, bifurcation, or chronic total occlusions. And we know that from the cheap definition, the anatomy is one of the things that can tell us if this is a complex PCI or not, and the true bifurcations, calcified lesions, and CTOs are definitely a complex PCI. And if you start doing a complex PCI, that means that you're already on the second step, that you already mastered some basic techniques, and that you want to learn something more to become a better operator. What things you, I don't know why this is, some of the things you have to do before even starting doing this. You know, it's really hard to learn something that you don't know. You have, before you start, you have to be very informed, you have to observe, you have to have a good mentor, and proctoring, I think, is very important to become a good and safe operator for the complex PCI. And of course, you have to decide whether the high-risk PCI is high risk for the patient or the operator. Of course, if you have this rather than this, don't even start. Of course, it's very important that the hospital management supports you. If you have this director rather than this director of the hospital, you don't start. Because, you know, complex PCI requires more than resources, requires staff members, requires nurses, requires good partners and colleagues. I mean, if your colleagues tell to you, I won't wait for you 4 hours to open a CTO, then there is no point of starting it. You have to have a good ICU, you have to give echo, and most of the times you have to have a cardiac surgery on site. Some questions that when I started doing complex PCI were very difficult to answer for me was, when I do the angio, should I do the ad hoc procedure or should I do it a second time? Most of the times, if I try to, if I have a really complex case, true bifurcation with calcium or a CTO that is, let's say, not seeing that it's going to be a very fast one, I prefer to postpone the procedure, have a good plan, because I always assume the worst. And when I start a complex procedure, I want to be prepared for all that I can imagine. Unfortunately, sometimes things happen that I don't even imagine they could happen. But for the most things, I want to be prepared. I prefer radio access because we know from the trials that it's safe, and most of the procedures, complex PCI, could be done by radio access, and most of the men, over 70% and over 50% of the women, you can deliver larger French catheter, like 7 French catheter, which is required for most of the complex cases. About the steps for all three entities, I mean bifurcation, calcified lesions, and CTRs, I try to follow the rules that smarter people than me invented. They're very well described in different publications. For true bifurcations, when you have really thick diagonal branch with difficult access, I prefer to stand this technique. My simple rules is protection for non-relevant side branch, limit the stand number, single stand, and restore the functional anatomy, and of course keep it simple but keep it open. This is a case of a true 1-1 bifurcation. It's of course no calcium, nice angles, nice diameters. So I think I could do ad hoc this procedure with a 6 French guiding catheter, and just by following the simple rules of the DK crush technique, the final result is, I think, very acceptable. For the calcified lesions, you have to do at least cutting and scoring balloons and rotablator. The other things are, well, we would love to have them, but in most of the places we don't have them. But don't start to do a really calcified lesion without imaging, without cutting or scoring balloons, and without a rotablator. The CTO, there are many things that actually are important. It's, I think, in my opinion, a whole different set of procedure, nothing to do with the other two. There are many anatomical scores that can guide your approach and your procedure, and according to this, there is a very nice statement from the Euro CTO Club, which can tell us actually how to proceed in every CTO. But unfortunately, one niveau rarely exists alone, and in most of the cases, when you have a CTO, you have either calcium or a bifurcation. When you have a calcification lesion, you most of the time have a bifurcation or vice versa. So in most of the cases, you have to deal with more than one of the three things, and in some cases, you have to do with all three entities. And now I'm going to show you a few cases which actually describes how these bifurcation, calcium, and CTO can mix each other, and how I manage the situations. That good planning is actually the prediction of a good result, and bad planning is a prediction of a bad result. This is also 1-1-1 bifurcation, but this time with a lot of calcium, not like the previous one, with very diseased side branch. So you see, this is not ad hoc procedure, it was planned procedure. It was planned for rotablation, it was planned for a double stent technique. First we rotablated, then we stented after pre-dilatation with the scoring monoris, we stented the side branch and crushed the stent with minimal protrusion. Then first kissing, then stent in the LAD, then pot, then again kissing, and final pot, and this is the final result. I just described you in brief the steps of the DK crush technique for bifurcation, which was facilitated by rotablation, but it doesn't always get that smooth. In this case, rotablation was also planned, but if you see on the third picture on the right, the burr stuck, and it stuck not because of the rotablation, it stuck because of bad planning of the rotablation. The burr that was used was 1.25 at a high rate speed, and as you can appreciate, it's not very gentle rotablation. All predictors that the burr would stuck. Initially, this wasn't my case. Eventually, it became. We managed to remove the burr, finish the rotablation, which didn't help a lot. You see that the non-compliant balloon and 26 atmospheres could not open, so we have to finish the procedure with the shockwave balloon and the final result. If you have sometimes, well, you have very calcified CTO. And in this case, we prepared with a 7 French guiding catheter, knowing that the support would be needed. You see, it's a short CTO, and you would expect that anti-grade wiring would be, well, would work out. So we managed to very quickly recanalize with the wire, but then the problem with the calcium came, so we had to put a water wire and rotablated it, but we were well prepared for this. We had the rotablator, we have the rotawire, we had the good guiding catheter with a 7 French approach. So my point is that you have to be prepared and to know what to expect in these difficult cases. But as I said, this was a short CTO. The other cases, again, CTO and calcium, but a very long CTO. Actually, this CTO is known from 1989 in this patient. We, of course, tried antigradely with a little bit wire escalation. Of course, as we anticipated, it didn't work out. So if you cannot cross through the calcium, you cross parallel to the calcium. We knock out, preparing for reverse cart. You see a very nice epicardial collateral from the circumflex, which we used for the retrograde recanalization, and by guide extension support and help, we managed to do the reverse cart in this really calcified RCA. And this is the final result. I'll move quickly because my time is almost over. This is a case of CTO and bifurcation. We managed quickly to engage the PL branch, which was the smaller branch, but we couldn't engage the PD branch. Even when we used the double lumen catheter and every other techniques that we could think of, we didn't want to do a try of antegrade re-entry dissection. So we used for retrograde crossing, I'm sorry for the frame rate of the pictures, this epicardial collateral, and again managed to finish the procedure. And last but not least, when you do a complex PCI, imaging, in my personal view, is very important. Imaging can guide you the procedure. Imaging gives you better results. Imaging saves lives. You know, it's known from the trials, from the meta-analysis. You have to learn, you have to know how to use imaging, and you have to use it routinely when you try to do a complex PCI procedures. You know, we know from this meta-analysis that as you see, very hard endpoints. Using imaging saves lives. And the last case I want to show you is how imaging can actually guide some of the procedures. It's again a CTO, an osteo lesion of LAD. This is a 39-year-old patient who refused surgery with an only remaining vessel, actually the right corner, which is dominant. So we didn't want to start retrogradely, so we do antegrade puncture with IVUS guidance, and the final result of the procedures. Thank you for your attention.
Thank you very much. Dr. Alexandrov, do you have any questions from the floor? Yeah, because it's a fellow dedicated session. Because it's a fellow dedicated session. And in practical point of view, if some of the fellows want to create or to be part of CTO program or challenging cases program, what's your advice how to start such a program? And this is question also to Professor Sianos.
In Bulgaria, I think it's not very easy. The best way is to go somewhere abroad and learn, which is not very easy. Not many people want to do it. There are, I think, very nice centers in Bulgaria where complex PCI is everyday work, so you can, of course, talk and go for some period in that places. In one place you can learn one thing, in another place another thing. Of course, go to meetings abroad, read a lot. Proctoring nowadays, it's not that difficult. Even teleproctoring, it's doable, it's manageable. 10 years ago, it was not really, in Bulgaria at least, but now it is. And I think these are the steps. And of course, you have to be self-dedicated and knowing that you have to invest from your own time, and that becoming a complex PCI operator won't become in 2 or 3 weeks. It will take years of dedication and a lot of work.
Well, first of all, it was a very nice, balanced presentation. If I cut down the entire presentation to one message, I would say that what you conveyed clearly is that complex PCI is a teamwork.
Yeah.
And teamwork is not only on the physician level, but teamwork on an administrative level, on hospital organization, on bringing nursing personnel together, educating the people. So that's the main message. Referring now to the last part is that also would say that complex PCI is not for fellows to start being. The main thing is that a fellow has to learn, engage well in a good program of learning the basic and start developing. And the complex PCI requires the framework of a hospital that you can have the power of your signature. So it's not about a fellow or not fellow or whatever, it's about someone that is dedicated to do it, and then he follows the step of advancement, and then he is in a place that he can take the responsibility of his own actions, guided. Because at the bottom line, if you start doing these procedures, initially helped or proctored or supervised or whatever, you're the one also to face the problems down the river. So the complex PCI thing, again, it requires a depth in the organization of many things, and above all, forward-thinking people and very dedicated people that they're prepared, because it's their price to pay on a personal level if you really want to get engaged and do this. So for all the people that they're starting a career, the message that I have to give, be aware of what you wish, it might become true.
I think that's an excellent end of this very first session dedicated for the fellows. Thank you to everyone.